There's an external stimulus that reminds him and brings him back and has him dissociate and remember these occurrences in his life of this trauma, which was, of course, World War I.
So, yeah, I think just taking a step back and making sure that everybody is prepared to identify PTSD, and in that case, acute stress disorder, as the single best diagnosis on an exam. It's best to break this illness down into 3 or 4 different components. Formerly, in the DSM 4, we actually had 3 pretty discrete symptom sets, SETS, where individuals with the illness were often identified as experiencing, for example, re-experiencing criteria, right? And I think most people would very quickly identify the flashbacks that you described, as well as nightmares, as re-experiencing criteria. And you'd be right. Unfortunately, I think a rather small percentage of the time on a shelf exam, but a significantly higher percentage in clinical practice, individuals may endorse no history of either nightmares or flashbacks, but still rule it because you only need a single example from the re-experiencing criteria, and there are 3 others. So I think for clinical purposes, it's a good idea to review what those 3 other diagnostic criteria are in this particular symptom set beyond nightmares and flashbacks. Anybody have any guesses of what they are? Number 1, intrusive thoughts. Number 2, physiologic reactivity, otherwise referred to as panic. And number 3, psychological decompensation, which is a rather broad topic, right? So if an individual reliably tells you they've never experienced or re-experienced a nightmare or flashback, if they do endorse any one of intrusive thoughts, which often may be misdiagnosed as obsessions and therefore obsessive compulsive disorder, physiologic reactivity itself may be reported as panic, therefore potentially misdiagnosed as panic attack or panic disorder, and then psychological decompensation. They still rule in for PTSD at this point. They do. So PTSD and of shorter duration, perhaps even acute stress disorder, panic disorder, and obsessive compulsive disorder would, I think, clearly be your differential diagnosis. We're going to assume no history of trauma, because remember, in 11 o'clock's conversation, the more severe the trauma, not only the more likely the individual is to develop PTSD and DID for that matter, but the less likely they are to remember it. So if your patient tells you no history of trauma, unfortunately, as a clinician, you can't definitively rule out a mental disorder as having resulted from trauma. Right? The second criteria set will help distinguish obsessive compulsive versus panic versus post-traumatic stress disorder, because now we're going to talk about the arousal criteria. And the arousal criteria themselves often are recalled as hypervigilance, which, by the way, may be reported by the patient as paranoia. So be careful about misdiagnosing severe PTSD as a psychotic disorder. And the exaggerated startle response, right? That gave this illness its former name of shell shock. Again, though, your patient may reliably tell you no exaggerated startle, no hypervigilance. But if they have 2 of the remaining 3, they still rule in, because from the second symptom set, you only need 2 criteria. Anybody guesses of what the extra or the additional criteria are in this particular symptom set? Impaired concentration, difficulty sleeping, and irritability. If somebody came to you with no nightmares, no flashbacks, no reported history of trauma, no hypervigilance, no exaggerated startle, but instead endorsed a change in affect, my friends tell me I'm more irritable. I have a shorter fuse, less frustration tolerance over the past 2 to 4 weeks, during which time I also have difficulty sleeping and a significant difficulty concentrating. What diagnosis is that individual likely to leave your office with? Yeah. So very, very quickly, panic disorder, obsessive compulsive disorder, and now major depressive disorder are easy misdiagnoses to make in someone that meets with a physician, a clinician that does not have PTSD in their differential, largely because perhaps there was no trauma history reported. The other symptom set are the avoidance of the numbing criteria, and this is where things get separated out, DSM-4 versus DSM-5. Avoidance in general, obviously, is something we always think of, but it's often very important to be mindful of the other signs and symptoms beyond avoidance that fit the criteria set here. And often this is the psychic numbing that we talked about, that is a dissociative state. And again, the low-hanging fruit here would be to misdiagnose as a dissociative disorder, especially derealization, depersonalization. All right. Now, for PTSD, depersonalization, derealization have been made qualifiers, whereas in DSM-4 they were not. So that's something to keep in the back of your mind as well. Again, fraught with potential misdiagnosis. Right. So, very quick primer on post-traumatic stress disorder. I think the clinical pearl will be to maintain that high clinical index of suspicion here, even when your patient tells you there is no evidence of prior trauma. Now, in this case, the prior trauma is self-evident. I mean, he actually had, or he saw combat, right? PTSD and acute stress disorder. Any questions? Treatment is biopsychosocial. You cannot go without therapy. All right, treating any anxiety disorder without therapy is not treating anxiety disorder. From a biological or somatic perspective, medications are often prescribed. However, in PTSD, the thing to remember here is that benzodiazepines are relatively contraindicated. This is one anxiety disorder that the evidence-based literature supports that benzos may make things worse. The other anxiety disorders, especially during the acute phase, benzos are often helpful. So that's something to remember as well. What else from this movie? Anybody take any initiative and catch any Winnie the Pooh? Nobody was inspired to watch Winnie? I mean, do you...
So I watched it as a kid.
All right, you saved the day there. Thanks for sharing.
So in the back of my head, I was definitely looking for some of the characters as they came up throughout the movie. In the back of my head. So you brought up this is kind of shifting back to the original question. You brought up how for PTSD you need therapy, and for the main character, it seemed as if once those stimuli kept kind of bugging him. One way he kind of got past that was by going out with his son into the woods and kind of putting them in a more friendly and fantasy context. I think that for PTSD, SSRIs are also considered first line. To what extent would you say that it isn't like a 50-50 kind of thing? I think the way I've studied it is it's a 50-50 kind of treatment plan. Is that different for everybody, or is it more of a consistent thing?
50-50 in what regard?
In regard of the level of importance for each the medication as well as the therapy.
Right. So, unfortunately, and I would have to look up in the literature because to answer that question from one's perspective of experience as a physician, we have a skewed population because our referrals are always those that therapy alone doesn't work. So I'd have to really refer to the literature. I would suggest that, again, as a clinical pearl, 100% of individuals with any anxiety disorder should receive psychotherapy. Okay. The only exceptions to that rule is when the diagnosing physician identifies a stressor that is going to be transient. Then I think it's perfectly reasonable to wait, observe, and upon termination of that stressor to see if the anxiety also terminates. And if it does within 6 months, you're dealing with an adjustment disorder, right? Which is an anxiety spectrum disorder because adjustment has been now moved into the anxiety spectrum disorders chapter, right? So, or chapters, plural, there are 3 of them. So that's one anxiety disorder, at least a spectrum disorder, that by definition will terminate upon resolution of an identified stressor. But that's the only situation in which the clinician should avoid or perhaps not refer someone and observe them if that's part of the treatment plan. But otherwise, 100% should go for psychotherapy. Now, I guess your question is, of those 100%, what percentage is likely to require further management and therefore the prescribing of an antidepressant or an FDA-approved medication for their anxiety disorder? I'd have to look that up. I really would have to look that up because, again, to answer that from experience would be very biased. Because 100% of my patients that I see for anxiety are because the outpatient therapy was not successful as monotherapy. Now, that said, there's a couple things to consider here, and that is with regard to this father-son relationship. Individuals, parents who struggle with a psychiatric illness that goes unidentified, untreated, or undiagnosed and untreated, certainly may meet with long-term adverse sequelae, right? Morbidity. And one of the forms of morbidity that we seldom talk about is their being connected to their children. And we see this often with postpartum states, that women who are or afflicted with peripartum depression and even postpartum psychosis have a difficult time establishing that initial maternal bond upon delivery of the child. And that might be meaningful. And again, if you want an over-the-top example of this, the film is We Need to Talk About Kevin. Anybody here see the film? Just one? Or you know what I'm talking about then, right? Okay. So again, over-the-top example, but certainly one that conjures up the discussion of that early maternal bond. We see the same thing here with regard to father and son. And as a result, we see the child resort to what is referred to as fantasy play, because the defense mechanism of fantasy is readily employed. So let's talk about defense mechanisms first, and then talk about some specific examples, including fantasy. What is a defense mechanism?
The defense mechanism is a way by which a person can cope with a stressor or acute situation.
It's a way in which individuals cope with the stressors. Exactly right. Let's get into a little bit more detail about what the stressor would entail. What's the stress about? The stress is always the product of what you would want to do versus what you're allowed to do. That always creates the stress. That always creates friction. And it's a subconscious process. And Freud called that friction anxiety. So the defense mechanisms are these unconscious processes that alleviate that very anxiety. The id wants to do something. I'll give you an example. How many people right here want to actually be at this lecture? Raise your hands. We got a few, all right? You're all liars, all right? Because your id impulse is not to be here, right? So give me some, there was somebody here didn't raise their hand, right? So any one of you could speak up. With regard to your peers that did raise their hand, you tell them what they really would prefer to be doing.
Anything else?
My sub-eye is mean. And then anything will need to be either eating, drinking, sleeping, or having sex. That's it. And if you are not acting on those base primal impulses, the id impulses, then you are not being governed by the pleasure principle. You are not being governed by that which pushes the animal to behave, period, right? We learned this from bees, we learned this from snakes, we learned this from fish, and by the way, it applies to human beings as well. So why are you sitting here in front of me other than the fact that your grade depends on it? That's real power. When you get on this side of the camera, that's power. Why? Why do something you don't want to do? Yeah, right? Because initially your parents told you that, right? And then your parental extenders reinforce that. And from these interactions, when you were asked to do something, maybe told to do something, and you didn't because you were governed by your pleasure principle, your parents made you know that that was not going to happen on their watch. However, they might have done that. And the first time that happened was probably around the age of 2, when they told you that you had to go into this specific room in the house to go to the bathroom now. And you told them no. And you pooped your pants right there anyway. And you quickly learned this ain't happening anymore. And when you first learned that, this superego began to develop. And your superego is that other subconscious process, part of who you are, your personality, that is the internalization of societal norms, initially funneled through your parents. And since that very first day where you tried to step over that threshold to the bathroom at the age of 2, you had two opposite but equal forces going on subconsciously. That caused friction, that caused anxiety. Next question. If that is the case, and that is the case, how could it possibly be that everybody continues to sit here doing something they don't want to do, that if it were their choice, they would not be doing yet? I don't see a lot, well, your masks are on, but I don't see any anxiety in this room. Why not? Right. That third and final part of your subconscious called the ego. Because through these ego defense mechanisms, the primary goal is to reduce the anxiety caused by the friction between the id and the superego. One example of such is called fantasy. This 2-year-old gets out of the bathroom, and after the ritual ends, looks around, and primary caregiver has left the room. And they are hit with the reality that parent cannot be omnipresent, and that parent is not perfect. This is incredibly threatening to that 2-year-old. So now we have some friction because the impulse is going to be thwarted by the superego. And that friction is going to cause anxiety. And they can actually resort to any of a multitude of defenses. And if one is fantasy, they might go to a different room and they may play with a stuffed animal. They may have a tea party. They may even play with and talk to an imaginary friend. All are examples of fantasy as a defense, ensuring that that anxiety does not result in a tantrum. In this case, we see the main character resort to fantasy as a way to resolve his conflict, his subconscious conflict between this id impulse that he has towards his father that will not be allowed to come to conscious expression. Thwarted by his superego, because subconsciously he's being told that's not the way a son should think towards his dad. Conflict, anxiety, fantasy into those woods, where he creates a retreat for himself that is protective from the harsh realities that do exist. And that's fantasy play. All right? Any questions about the process of what then launched the genre, the franchise of Winnie the Pooh? From this film, what else did you observe? What else would you like to discuss?
I think it's interesting. Like Winnie the Pooh is like a whole. Like each character is supposed to represent a different disorder, and like Winnie the Pooh is the ADD, Tigger is ADHD, and so on. Piglet is anxiety.
Take this a little slower.
Yeah.
Say that one more time.
Like Winnie the Pooh is supposed to represent ADD, Tigger is ADHD, Piglet is anxiety. The rabbit is OCD. Eeyore is depression. And even Christopher Robin is supposed to be schizophrenia. I don't know, because I always saw after movies, I don't know if this is presented in this movie specifically, but like Winnie the Pooh, the cartoon, is evident there. And it's even like, I think it's even like a test online. I know it has like probably no real meaning, but you take it and they give you a character based on the answers.
So let's talk about that. Let's take these characters one by one. So let's start off with Christopher Robin. All right. you think schizophrenia, let's just call it psychosis in general, okay? What evidence is there to suggest that Christopher Robin is afflicted with psychosis?
Hallucinating. So if you argue that Christopher Robin is hallucinating and truly believes that the animals are real, talking to him in the neighborhood, then you could make the argument that that is one qualifier of psychosis, having those hallucinations.
Right. So let's talk about this process. So as a child, and Christopher Robin clearly is the young Milne, right? I mean, that's who it is. So there is some real life linkage. But we have a child who's created this fantasy, this 100-acre wood. Why not just suggest that this is part of fantasy play and completely normal? Any thoughts as to, especially when we transition to the character of Christopher Robin, anything about the character of Christopher Robin that would go against that idea? I mean, as a clinician, any behavior that presents to your clinical attention should be deemed normal until proven otherwise. What is there that's part of Christopher Robin's character that perhaps proves otherwise?
So I think my interpretation of Christopher Robin in the movie, the way he's presented as a real life character, he's a child that experiences some level of neglect in a way. Even as the book takes off and he becomes an international star, in a way that leads to even more neglect, with his parents not really looking after him or taking care of his needs. So my argument would probably be that it's rather than hallucinations, the characters that he creates is the defense mechanism for that, rather than going straight and jumping to psychosis diagnosis.
Okay. I don't disagree. In the how old's Christopher Robin?
Like 8.
Right. He's a little old, right? Remember, when an individual incorporates fantasy as part of normal childhood development, we're talking about something that would be developmentally appropriate. When that individual is beyond the age range, I mean, if I were to tell you that I'm going to actually stop the lecture here, we're going to come off a Periscope too, but that my friend here is going to continue and complete the didactic, I think everybody in here would be a little concerned. All right, because for a 4 or 5-year-old to do it, that's one thing. But for a 34-year-old to do it's another. That's a joke, by the way. So while it was appropriate for Milne to do it, it looks like it would be developmentally inappropriate for Christopher Robin to have this level of fantasy play governing his behavior. And when that happens, we have to consider there might be something else going on. Now, if an individual has age inappropriate or otherwise maladaptive fantasy as a defense, they are at risk for developing a specific personality disorder called the schizoid personality disorder. I mean, in this case, the child, in this case, perhaps even the young adult, would, I think, prefer to retreat into the woods and operate in solitude. Right? That's the schizoid personality. And there is this autistic retreat into themselves to create this inner world, the 100-acre wood, so as to protect themselves from the harsh reality that truly exists. That's the schizoid personality. And if this were to happen, if this is what we're seeing in Christopher Robin, then we know there's a progression of this illness, which is a type A personality disorder, to a future psychotic disorder. That is, all the type A personality disorders, the schizoid personality included, are risk factors for schizophrenia and other psychotic disorders. So I think that's how this connects to psychosis in Christopher Robin. And even though in the textbook, we think about this as a risk factor, that there's a nice lineage and a timeline, the fact is that during periods of stress, you can actually see stress-induced psychosis within the personality disorder. So the individual who's schizoid, who's living in the woods, has a stressor, and they have a psychotic break. Might be brief, but that's what happens. The infamous case study here is the case study of Lawful. What do you know about Lawful? think you guys may have heard about this already. Lawful is an individual with fairly severe schizoid traits, if not perhaps undiagnosed schizoid personality disorder, remains to be seen. But he is in the backwoods, and one day he comes across a hiker and decides that it's way too overpopulated for him. That's the level of solitude he prefers. So he goes back to his original campsite, which is a several-day hike, and when he gets back there, he actually sees that a road has been built there in the interim. And that level of stressor results in a psychotic break. Now, we don't know, I mean, in terms of fully understanding Lawful, we have to know his history, because years prior, as a sophomore at Harvard University, Lawful took part in a research study in the Department of Sociology. And as a product of that research study, he was psychologically tortured. He had his most intimate thoughts read over a loud mic or a live mic to a lecture hall filled to capacity. And physiologic parameters were monitored. And of the 22 subjects, he had the worst reaction to the psychological torture. So there may have been a pre-existing schizoid personality, but there was certainly some evidence of trauma there as well. From there, he goes to the University of Michigan, earns a PhD. From there, he goes to Cal Berkeley, but unfortunately has to resign prematurely due to pretty much difficulty interacting with others. And upon his resignation from Cal Berkeley, he retreats to the backwoods of Montana. Case study sound familiar?
Yes.
Who is it? It is. Right, psychotic break brought upon by a stress. All right. Now again, there was predisposing factors, and perhaps that included schizoid personality disorder. None of the future psychiatrists in this room were there, so we don't know. But certainly that precipitant seemed to be that road. Might the same thing have happened to Christopher Robin? Did he see a road built? Did he see evidence of the external world invading his sanctuary? And if so, perhaps he does stand for a psychosis, but at least he prompts the discussion of it. All right, so that's Christopher Robin and psychosis. Next character, and I'm gonna ask all the characters but Winnie itself.
Okay. So it's like a list of the Winnie the Pooh characters.
One by one. Piglet, right. So Piglet's an unspecified anxiety disorder. I think his tagline of "Oh dear" is certainly consistent with that. Especially when you watch the cartoons, he does come off as being anxious. I don't really recall in watching anything that starred Piglet if there was discrete obsessive compulsive traits and/or panic, but certainly anxiety disorder. No doubt about it. Let's switch over. So that now we're going to go to Rabbit. Why do you think Rabbit is obsessive compulsive?
So, at least on the note of that, I wonder if Rabbit is more so obsessive compulsive personality disorder rather than obsessive compulsive disorder, because at least from what I remember, he doesn't default to a behavior to kind of dissipate the anxiety over some stressor in his life. He's more so at the controlling type, wants to be in charge of everything that's going on, wants to follow his blueprints for how things should happen. And if it doesn't happen that way, that does cause anxiety, but it doesn't default to behavior. So I wonder if it's more so personality disorder rather than OCD outright.
That's a good point. So let's backtrack just a little bit. Obsessive compulsive personality is the type A personality. It's the individual who is a micromanager, that they work at the expense of pleasure, that they're frugal and have a very miserly spending style. In the context of these traits, if maladaptive and clinically significant, obsessive compulsive personality is likely the single best diagnosis. Obsessive compulsive personality really does not deal with obsessions or obsessive thoughts, nor does it include in the diagnosis the actual clinical criteria, compulsive behaviors. Because if an individual demonstrates either or both, then we're talking about OCD. talking about the anxiety spectrum disorder, specifically obsessive compulsive disorder, where an individual struggles with either or obsessive thoughts and or compulsive behaviors. It looks like we may have both in play here. So there's certainly comorbidity with regard to these two disorders. They are named the same because they have a common etiology. So the fact that we see some comorbidity should not surprise anybody. Rabbit does appear to want his garden in perfect order, and that perfectionist style is indicative, supportive, if not defining, of obsessive compulsive personality. But he does have intrusive thoughts, obsessive thoughts as well. And to that extent, we would have to consider OCD, even in the absence of compulsive behaviors, to also be in the differential. So I think he does have OCD, but I think that's part of the picture, to your point. Yep. That makes sense? By the way, does anybody know what the shared or common etiology of these two illnesses, the reason why they were actually named similarly, are? It's called isolation of affect. It is yet another defense mechanism where an individual is made to think about something they do not want to think about. So if made to think about something, what individuals can do to protect themselves from the trauma of thinking about things again is that they separate the idea from the affect. The idea comes to conscious awareness, so you can talk about it with your friend, with your parent, with your professor, but you're not going to be emotionally invested in that conversation because the affect has been separated and isolated in your subconscious. And that is thought to be the etiology of both obsessive compulsive personality as well as obsessive compulsive disorder, hence why they're named similarly. Now, over time, that isolated affect is not going to be able to stay in your subconscious. It's going to slowly but surely come to conscious awareness. And as it gets closer and closer, the individual is going to experience anxiety. How are they going to dissipate that anxiety? Well, another defense mechanism. And if the first one's being overwhelmed, you got to reach for number two. If that second defense mechanism is undoing, then you're likely to participate in a ritualistic act, hand washing, counting, that diverts your attention from that rising anxiety, therefore dissipating it. Hence OCD. On the other hand, if everything that's going on subconsciously, all this chaos, is turned to its 180-degree opposite via reaction formation, the internally chaotic individual is going to then personify total perfection, and that's OCPD. Right? So depending on what the secondary defense is, has a lot to do with which one of the two disorders the individual is going to manifest. And of course, if both are in play, guess what? You have comorbidity. Right? So the overwhelming of the isolation of affect and the resorting to undoing may result in OCD traits in rabbit, but the Eeyore. This might be one of the more straightforward. So depressive disorder. I've never in my life, and I've been watching Winnie the Pooh, I think since I've been 5, seen Eeyore with a smile on his face or during a sustained period of euthymia. So maybe not major depressive disorder recurrent, but perhaps even dysthymic disorder, but certainly a depressive disorder, right? Okay. And then Owl? Yeah, he's got difficulty communicating, both verbally and non-verbally, spelling. I think these cognitive deficits are indicative of an underlying sleep disorder. I mean, this guy should be asleep during the day and awake and alert at night. He's an owl. But I've never really seen a Winnie the Pooh episode where that's taken place. He's always awake during the day with his friends and presumably sleeping at night. And might that circadian rhythm disturbance, circadian rhythm sleep disorders are a subset of sleep-wake disorders in the DSM-5, might that be contributing to his cognitive deficits that include memory, that include speech, and perhaps other forms of nonverbal communication, like spelling? Right. So I'd investigate for a sleep-wake disorder, perhaps even within that context, a circadian rhythm disorder. That's something to consider.
I'm not sure if it's necessarily on that same kind of thought, but just with Owl, I remember like you would sometimes mention, like say, faux scientific terms or talk as if he knows a lot about the subject and he make up a lot of words. So could that be maybe a product of an aphasia in terms of he thinks he's making complete sense, but when you actually listen to him, there's nothing there.
Yeah, I wonder if it's a neurologic syndrome, even confabulation.
Right.
Yeah.
So I don't know how kind of maybe is even psychiatric.
Yeah. Yep, I agree. No, I agree. And again, I think when you look at these constellation of symptoms, we do know that sleep disorders, sleep disturbance in general, can actually induce all of the above. So I think that's where the investigation might start, especially when you realize he's an owl. And all of this occurs during the day, which would be similar to us having these types of behaviors identified during the night. All right, so let's stop for a second here before we get to Winnie the Pooh. Oh, Kanga, I'm sorry. Kanga and Rue.
Yeah, I can't mix that up. I think Rue was going to have ADD.
Got it. And about Kanga?
Kanga's a very overprotective parent. There might be speak to some sort of social anxiety disorder. She's like super overbearing.
Yeah, I agree. I think we're gonna group Kanga in with Piglet. I think there's something going on with the anxiety disorder here. Absolutely. Right. All right. So, just running down the list in no certain order, we have Kanga and Piglet as anxiety. We have Tigger as mania/bipolar. We have Rabbit as OCD. We have Eeyore as depressive. We have Christopher Robin as psychotic. By the way, that also includes delirium, right? They're really the same thing in terms of the initial thought process of somebody formulating a diagnosis. And we have Owl as a sleep-wake disorder, right? What does that list, or what do those disorders in that list all have in common? Again, I'll go through them one more time for you. Bipolar and related disorder, depressive disorder, anxiety disorder, obsessive compulsive disorder, psychotic/delirium, and sleep-wake disorder. That is the easiest way to remember the mental disorders that can all be induced by cocaine. Right. So, looking at it from a little bit of a different perspective, a patient presents with a chief complaint of blank. The chief complaint allows the clinician to formulate a provisional diagnosis within the blank disorder class. That could be depressive disorder, it could be the bipolar and related disorders, etc. No matter which classification we're going to start with, the clinician must always rule out the direct and physiologic effects of a substance as inducing that particular disorder. So too must they rule out an underlying medical condition. But this group should focus on the substances first. And I think in actually formulating or case formulating a patient chief complaint, I think we've got this part down very nicely, albeit within 2 weeks of your clerkship. I mean, hopefully we've hammered that home enough where substances and medical conditions always come first, right? Having said that, when the next question is, let's say it's depressive disorder, which substances may induce what we're seeing? There's always hesitation because there's a list there that either during intoxication and or withdrawal that you're going to have to do some guesswork. And a lot of that is informed by your experience, but unfortunately, it's very difficult to experience that broad range of pathology. So you're going to have to go to the DSM, you have to study it and memorize those lists for your test, unless you remember Winnie the Pooh. Because now that you know the characters of Winnie the Pooh, you know every single type of disorder that may be induced by the intoxication of cocaine, at least for that one substance. And of course, that includes any stimulant, including amphetamines, even synthetics. All right, so at least Winnie the Pooh, and more specifically the characters of the 100-Acre Wood, I think well represent all those mental disorders that may be induced by cocaine intoxication. All right, now, they could all be induced by cocaine withdrawal as well. There's one little asterisk there, and that is nicotine withdrawal can also induce sleep disorder. I'm going to take it back. Strike that. We'll get to that a little later. Don't worry about that. Right. For all intents and purposes, cocaine withdrawal can induce all the above as well. There's one other disorder that cocaine can induce that we haven't listed yet. And similarly, we have one character, perhaps the main character, that has been unidentified up until this time. So I think we all know the character is Winnie itself. What mental disorder have we not yet discussed that may be induced by cocaine intoxication? Nope. Which would be nice. It would be perfect if it was eating disorder. Because I think all of us can easily remember Winnie as having an eating disorder. It's actually sexual disorder, right? There is such thing as a cocaine-induced sexual disorder, right? So if anybody wants to make the cartoon to make us remember that Winnie the Pooh, the character, represents sexual disorder, you go for it. It's not going to go off my YouTube channel. But the one thing that I will say that has been a discussion on different Reddit threads is that this character is not anatomically correct. I'm just going to leave it there. All right, for you to remember, sexual disorder could also be included in the 100-Acre Wood. All right, so I'll point you towards Reddit. You have fun with that one. All right?
When you say sexual disorder, you mean a dysfunction or?
Yeah.
Okay.
Yeah, it's a dysfunction. Yeah. There's no such thing as a substance-induced paraphilia, and there's no such thing as substance-induced gender dysphoria. So yes, it's a dysfunction. Again, pick one, create that video, and you'll never forget it. But again, it's going to be a long day before I put that up on my YouTube channel. All right. So anyway, one disorder, one character. You match Winnie up with sexual disorder the best way you can. But for otherwise, I think all the characters of the 100-Acre Wood, I think quite nicely linked to all those mental disorders that may be induced by amphetamine/cocaine/stimulants. Any other thoughts about the film we were discussing? All right, we'll end here. For those following at home who have the Zoom link, we'll be back in about 10 minutes for our case presentations. Otherwise, we'll see everybody back next week.